So that frames the setting for the next panel, which is going to deal with professionals in a changing environment. And this is a topic that in many ways follows what we've already been discussing, which is we have our disciplines which tend to be in some ways separate and isolated from each other, and yet we know that the future really requires us to think much more about working in teams and interdisciplinary work and education, transforming the way our paths are organized and followed. And I think that is literally going to be a big part of our discussion this afternoon. What's the scope of work? Who should do it? What are the responsibilities that define it? And how do we craft a new environment as we go forward? And as they're getting mic'd for our next session, I'm pleased to introduce our moderator, who's Mark Smith. He's going to come forward. And Mark, as you know, is the President and CEO of the California Healthcare Foundation. He's been in that role since 1996. This is a nonprofit organization that has as its singular purpose improving the lives and health of individuals in California, particularly those in underserved communities. Mark is a leader in many ways, of course, a member of the Institute of Medicine. He's also a faculty member at UCSF. He works at San Francisco General in the Positive Care Clinic and really has been a voice of reason in these changing times. And if his other panel members can come forward, I'm going to let him introduce them and we will go forward.
Thanks, Bill. Good afternoon. Good afternoon. Boa tarde. Buenas tardes. Bonjour. Guten Tag. We're waiting on one more member. We've heard an awful lot today about the task of creating a new kind of health professional. And we've got a great panel to discuss what needs we have for a changing healthcare system. So let me introduce them to you first, and then my job is to give a few framing remarks and get out of the way. First, we have Martha Hill, Dean and Professor of Nursing, Medicine and Public Health at the Johns Hopkins University School of Nursing, which I suppose is not Bloomberg. That's the School of Public Health.
That's correct.
Yes. If anyone here would like to name the nursing school.
Yeah. For $100 million.
$100 million is the going rate, I understand. Lucinda, Maine is Executive Vice President and CEO of the American Association of Colleges of Pharmacy. You've switched positions, okay. Ed O'Neill, recently retired Director of the Center for Health Professions at the University of California at San Francisco, and Steve Sonis, Clinical Professor of Oral Medicine, Harvard School of Dental Medicine, and Chief and Senior Surgeon at the Departments of Oral Medicine at Brigham and Women's Hospital and the Dana-Farber Cancer Institute. A few opening comments. As you heard from Harvey earlier today, I was privileged to chair the Committee of the Learning Healthcare System in America that recently put out this report, Best Care. And so in some ways, I'd like to summarize for you this changing healthcare system that we now see needing a changing group of health professionals. And the two things that we started with really were the cost problem, which is by now no news to any of you, and also the complexity problem, which David Blumenthal talked about earlier today. The fact that we've made such dramatic and in some ways miraculous biomedical progress and informational progress that we've now reached the point where no single human brain can manage this information by him or herself. We also tried for an atmosphere of optimism. As you heard Don Berwick say, it's a confusing and in some ways demoralizing time for people. And a friend of mine, when I told him I was chairing this IOM committee, he was a residency mate, and I said, oh, geez, the IOM, everything is broken, the system's all messed up, everything's terrible. I said, well, gee, maybe that's not really quite the right message we want to send. And so the message that we tried to send was frankly one of both frustration and optimism. And the optimism was based on the frustration was based on the fact that we haven't made more progress since these seminal reports than we have. The optimism was based on the notion that there are at least 4 new tools that we have to make progress that we didn't have when these reports were first issued. And they are, first, the enormous computing power that is now both ubiquitous and affordable for professionals, institutions, and patients or people alike. Second, the connectivity that allows professionals to be connected to each other, connected to patients, and patients to be connected to each other in a way that would have been inconceivable really a decade ago. Third is progress in organizational capability and management science, lean theory, Six Sigma, patient smoothing, that allows us to make better use of resources by applying some of the techniques of industrial engineering and management science that are old hat in retail, but novel in healthcare. And fourth, collaboration and teamwork, both among professionals and between professionals and their patients, something that we've heard a lot about today. And so I want to commend to you those things in part because those are the things that are shaping the new organizational context in which health professionals are working, and in some ways shape the things that they have to be good at. Now, I'm going to be slightly irreverent by referring both to Sam Martin and to Health Affairs. In 2009, Health Affairs published an article, a special edition supported in part by the Foundation on IT, in which they studied, among other things, the experience of Kaiser Permanente in implementing an electronic health record in its Hawaii region. And in the time between 2004 and 2007, office visits decreased, annual office visits, age and sex adjusted, decreased by 26.2%, with comparable decreases to primary care doctors and specialists. Provider satisfaction went up, patient satisfaction went up, quality rankings went up. In Kaiser, that was great. In most of American medicine, that's a financial disaster because you've just reduced the thing that gets people paid. And so in some ways, we should not be surprised that it's taken so long for some of these innovations that ripple through the rest of the economy to ripple through healthcare, because there aren't many of us who would run out to adopt an innovation that would reduce our income by 26%. The second thing I want to say is an homage to a man named Sam Martin. And I know in the audience today are Risa Levitsa-Moray and Gary Gottlieb and Raynard Kington and perhaps others who benefited from the mentorship of Sam Martin. So among the many important things that Sam Martin once said were, if you want to make a silk purse out of a sow's ear, you have to start with silk sows. So when we decry the lack of interest or competence in mental health by today's health professionals, I would simply point out that today in 2012, for you to become a doctor, you have to demonstrate interest, competence, and excellence in physics, but need not have taken a course in human psychology. If you want to make a silk purse out of a sow's ear, you have to start with silk sows. We are still in an era in which, on the one hand, we say we want health professionals to work in teams, and yet I, like many of you, was told early in my training that I should be congratulated for having chosen the last profession in America where nobody could tell me what to do. And so we are, many of us health professionals, self-selected for independence, rugged individualism, lack of interest, ability, or facility for teamwork, and excellence in the biomedical sciences without compensating excellence in any of the social sciences that we now say are important for health professionals to master to work in a new system. And one of the questions is, how come we keep saying, I've been hearing for 20 years, we need to work in teams, and yet I'm not convinced that we've quite gotten that right yet. So one of the things I'm going to ask our panelists to do is to go beyond many of the things that we've heard almost universally this morning about the way we should act, and talk about why we don't act that way, and perhaps in their comments or in my briefly moderated session, or perhaps in the responses from arguably the smartest people in America, we can get some answers to why it is the things we say we want to do, we seem to have such difficulty doing. So with that small challenge, let me start with you, Martha.
Well, thank you very much, Mark. And I'd like to begin by bringing up three issues. One is scope of practice. One is the need for new roles, and related to that, the need for more innovation in how we deliver care. So you all know about credentialing. You all know about licensure and certification. And these are important things that I'm going to propose. We might want to think about them as sacred cows. Now, I'm an optimist. I'm also like disruptive innovations. So I'm interested in the possibility that we might do some pilot testing in certain states where we get waivers from the state boards of medicine, the state board of nurse examiners or whatever, and say, let's try to do some things that are going to reach some needed objectives. Now, there will never be enough physicians, nurses, or dentists, pharmacists. I'm mentioning those two because they have been notably absent in the comments this morning, and other professionals, and say, there'll never be enough of us to meet the demand and meet the need. So we need to reinvent ourselves or rethink the worlds within which we practice. And I do think that the issues of licensure and certification, and in that I will include not only of us as professionals by our professional organizations and societies, but also of what's happening with education and accrediting and of hospitals and of others. The bureaucracy has become really quite impressive and very intrusive and rather controlling. So how do we assure quality? How do we increase efficiency and effectiveness, control costs, while we manage to live within these bureaucracies? And I think one thing we might think about doing is trying to change them so that we still have the assurances there. I'm not talking about sacrificing any quality, but I do think, here's an idea. What about a restricted license? Let's say you could go to nursing school or medical school and you are pretty sure that what you want to do is care for elders. Well, do you really need OBGYN? Maybe you need the GYN, but do you need the OB? Do you need peds? Do you need labor and delivery? What if you could do a curriculum where you opted out of those, knowing you'd get a restricted license that says you never can do this unless you go back and retrain and reinvent yourself and get an expanded license? Think of what that would do in terms of the rapidity with which people could be put through and graduate, and with the reduction in debt, and some other very interesting, it would take some of the fight off of the clinical sites, but they're all too short. But I propose that as one idea of a disruptive innovation that we might proactively take on. This morning there were some very interesting conversations, and with all respect, I'll disagree with FF. I think we should be looking at what do patients need? What do patients and their families need? And then back our way into what would it take to meet those needs? What are the competencies that are needed? And then who can learn those competencies, those skills, that knowledge, develop the clinical judgment? And we've seen, you can call it task shifting up and task sharing down, whatever you want to call it, it's been going on forever. It used to be that only William Osler carried a thermometer in a little box. Every house has a thermometer. Think about the transition now to where blood pressure cuffs and scales are in every house and patients are self-monitoring. We can take this notion of pushing care out from the hospitals has now gone to the urgent centers or the medi centers or the suburban clinics. One-day surgeries are now being done in many, many sites. Nurse practitioners are doing colonoscopies. This has been going on for decades and decades. It is not new. It needs to be done and it needs to be continued. So who can learn? Who has unique knowledge? How do we position them that they are then able to use it? There are certain things that only physicians are educated and prepared to do. They should be able to concentrate on that and have a lot of some of the other things that could be shared, and more shared with patients and families, as was made this morning as a point. Two comments about new roles. They too have been evolving forever. The most common one we're hearing about today is the community health worker. These were lay people of and from the community of interest. They were volunteers. They served as ambassadors and as communicators, translators. What we're seeing now is the increasing professionalization of community health workers. There is talk about licensure. There are tremendous issues around reimbursement for services provided. They're being written into legislation. I will tell you from my own experience, I think they're absolutely marvelous, but there are very serious issues around preparation and training, productivity, reimbursement, and the desire among many of them for increasing professionalization, getting degrees, getting certified, and so forth and so on. So what we're seeing is the increasing professionalization of what was a volunteer, unpaid, lay people of and from the community who are becoming less and less of and from the community. And it's an interesting thing to watch, not too surprising, but it does change the nature of the role. The other role that's interesting now that's undergoing a lot of revitalization is the role of the care coordinator. And we have had the nurse care coordinator in the sky, on telecall and from wherever they are, coordinating care with a lot of very good outcomes. But increasingly now, the connector between what's going on in the hospitals and in the managed care organizations or the accountable care organizations and the community care that was discussed this morning is somebody has got to be the guardian angel sitting on the shoulder of that patient wherever they are and monitoring the coordination of care, which has not yet gotten to the point of integration and coordination that we're going to have. Finally, I think on disruptive innovations, we need to be looking at the mutual goals that we all share, lowering the silos, recognizing the fact that there is tremendous overlap of task competency, as high as 90% in primary care for PAs, nurse practitioners, physicians, and embracing it and taking advantage of it and putting together teams that are flexible and fluid, where the skills of being the team leader should come from the characteristics of the individual members of the team and their training and their education. So one final anecdote. One time we were at a Hopkins alumni fundraiser, and the president was talking about the importance of the School of Medicine and the role of the physician as the captain of the ship. And I was sitting with my husband, who's a medical school graduate, and some other friends who were medical school graduates, and I started to stand up, and they said, "Oh, please." My husband said, "Please, no." And I said to the president, with all respect, the captain of the ship, I think the ship is the clinical care unit, whether it's the cardiac ICU or whether it's a community-based clinic. And in many of these settings, I would propose that the analogy should be that the physician is the admiral of the fleet, back at headquarters, on call. And the captain of the ship could be whoever is the person who actually, in fact, is coordinating and leading the group, regardless of their background or their preparation. And I suggest that we think about that. To be effective and efficient, we're going to have to focus on the competencies while we all are working on continuous quality improvement.
Thank you. Lucinda.
So I'm going to take on some of the same issues, but maybe a little bit from the inside rather than as boldly as you did, Martha. The thing that's been clear throughout the entire conversation today is that so much is changing. And it's changing for all of us, not the least of which is our patients. And I think we understand so little at this point about the impact of that at the end of the day. Maybe they're the captain of the ship, if they're equipped with the tools to do that. Because, depending upon our age and our education and the experiences that we have, and this is true of both of individual patients and as providers, we operate with a whole lot of stereotypes, a lack of knowledge, and yes, even sometimes fear, which we bring into our encounters with other professionals, and certainly that's true from the role of the patient. I'm going to use pharmacy as an example twice because A, I know it very well, and I think we may be a microcosm of some of the changes that we're talking about here today. So in pharmacy, it's not uncommon to have a consumer ask innocently, "Do you have to go to college to be a pharmacist?" Or in contrast, when that person is administering an immunization or maybe managing a patient's anticoagulation status, they then might look up and say, "I didn't know a pharmacist could do that." And it's clear that what we think and what we see and what we experience really changes the perceptions that we have about who can do what within this system. We named a lot of factors this morning: the aging of the population, the chronic disease epidemic, and other factors that really do set the stage for this task changing, task shifting, both up and down the chain of disciplines, of credentials, and of expertise. Again, in pharmacy, we are not alone in the fact that we've experienced a fairly dramatic change in education for our providers in response, at least in part, to the explosion of knowledge and this need for a change in who does what. And I would emphasize that this really creates a lot of uncertainty. And that it does that in some cases for a relatively long period of time, a generation of providers perhaps. When there are individuals in a profession with different levels of preparation in terms of both their degree and postgraduate training. And I would have to say that nursing may be the poster child in that regard. So, while it's easy, I think, to say that every contributor in the system should practice at the top of their license, I don't think it's quite that easy. I think we need to spend some time focusing specifically, and I'll come back to this, to the credentialing and the privileging strategies across the continuum of care that will allow us to seek some clarity both within professions and across between professions. And this plays out a lot in national dialogue, and we can talk real nice about these things. It plays out not so nicely typically at the state legislative level, where the real battles to ascertain who should really be able to do what for whom. But I really believe that healthcare is local, and that this is one of those issues that we're going to have to grapple with. I think delegation and the redistribution and sharing of responsibilities that used to be solely the prerogative of one domain is truly a thing of the past, and that some of those tasks shift to licensed personnel, but as I'll emphasize in a minute, sometimes they actually even go to unlicensed people. Now, this community care worker is a fascinating case in point. But again, I'll draw from my own experience in pharmacy and talk about this movement in both directions. We completed the educational shift. I like to call it the 50-year debate that ended just in time about whether or not everyone should receive a Doctor of Pharmacy degree. And now, for about the last decade, all graduates of our schools and colleges of pharmacy have graduated with a PharmD. And over that same period of time, not coincidentally, medication use has become increasingly complex. It has become even more expensive. It used to be easy to ignore that it was 5% of the healthcare spend. That's not the case anymore. And in some cases, and specifically the IOM has documented that it can be downright dangerous. And so as new medication management roles have been identified and have surfaced, and my graduates are finding that a greater percentage of their career is directed to helping other clinicians and patients manage complex medication use. They've obviously had to change some of their attention to the traditional book of business within pharmacy. And ironically, at the same point in time, the traditional book of business has grown. That contributed to a radical shortage of pharmacists over the course of the last decade. And this is a really challenging scenario for pharmacists because safety is number one. And if I can't make sure that I get the right product to the right patient with the right directions for use and some modicum of an understanding of how it works, I am very reluctant to delegate that task away. And in our case, there is no established educational core for that other professional, that technician, pharmacy technician. There is national certification, but there is great variability, and pharmacists are reluctant, therefore, to wholeheartedly give over that portion of their traditional business and take on the very necessary new roles without some assurance that they are giving that over to somebody who's competent and qualified to take that on and do it well. We know that they can do it. We know that technology supports that, but it's not uniformly available and supplied. So just with that case point, I raise 4 issues. And that is, as we see these changes occur, can we have an agreement on the level of education and regulation that new professionals, including paraprofessionals or technicians, truly need? How good are our quality assurance mechanisms at both the systems level and the individual practitioner level to allow us to adequately assess if the work of each participant is done safely, efficiently, and compassionately? And then who determines what new roles can be assigned to each professional? especially when the shifts in roles go between two regulated professions whose work is overseen by different boards, regulatory bodies. And then outside the institutional setting, and I believe in most institutional settings, the processes of credentialing and privileging are relatively well defined and managed. But that is simply, I don't believe, the case outside of the institutional setting very often. And I'm not sure that we have the resources and the tools that we need to guide the evolution of roles to ensure at the end of the day that the public's health is protected. We'll hear from the next panel that team-based care is where we want to go, that it's more efficient. Practitioners even like it better. And so I think it's really imperative that we all commit to making sure that our clinicians, both the ones in school today and the ones we've graduated for decades, are learning about with and from each other so that they learn how to communicate, they learn how to share and coordinate care, but above everything else, that they learn how to trust one another.
Thank you. Ed?
Thanks, Mark. Part of what I have to say will sound a little bit like Mark, and also echo Martha and Lucinda as well. Mark and I are twins, actually separated at birth, so we oftentimes sound alike. So I've just retired, as Mark said, and after 40 years, some of you know I've worked in these vineyards, and I've been to this meeting continuously for the past 40 years, where we pledged ourselves to work to integrate a system of care, where we told our colleagues that we would be patient-focused and consumer-responsive, where we would build efficient, cost-responsive systems of care, where we pledged at the altar of team-based practice that that was essential, where we thought an even broader concept of collaborative practice was the right culture to create to move forward, where we would focus on the community and learn how to take care of that community, and if our parties is still here, where we would actually integrate physical and behavioral health for the first time. I've written those studies for the IOM, for the Pew Health Professions Commission, and as I look out over here, I see my fellow members of most of those study commissions. I'm from Alabama. We always are fixing to do something in Alabama. We've been fixing to do this. Everybody here is smart. Mark said, arguably, the smartest aggregation of folks in the country. We have about a third more money than we actually need to run the healthcare system, and I don't question our earnestness in doing it. But we don't do it. We blink. So, as some of you know, I'm a historian, and so I can actually shed a little bit of insight on this. What value trumps our commitment to these other values? My friend and colleague Fitzmullen raised the post-Flexnerian concept this morning, so I want to take you back 100 years to Flexner and to his times, because it's the Flexnerian value of the autonomy and the individuality and independence of the profession that makes us blink when we think teams, when we think systems, when we think community responsive, when we think cost aware, because it's a deeper held value. It's an important value, but that's why we don't follow through and why we're only fixing to do these things. 100 years ago, Abraham Flexner found emerging new biology in the West. He saw new forms of research emerging. He saw that the professional, all of us, could be the agents, the technical agents of the power of that specialized knowledge that was emerging. He also was fearful, as most progressive reformers in his age were, of the growing corporatization. So he thought that the individual professional, autonomous, in a John Galt kind of fashion, was a good hedge against that growing power and authority. And, not in his best moment, like most progressives, he was fearful of a growing diverse population, particularly on the east coast of this country. Catholic, Eastern European, Southern European, and felt as if the progressive power lodged within those professional communities that were dominated by the older establishment would be the best way to maintain order. So he created that report in deference to him, and some apologies to Shakespeare. The recommendations, you'll recall, were get thyself to a university, to make the professions the agents of the new science, to see the professions as the creators of the new science. So we combined the role of clinician and researcher and valued that and have continued to for 100 years. And deceptively enough, we created what I once described as the iron triangle, and it's consistent with Martha's observations, of accreditation, licensure, and education. And we raised the boundaries. But what we were really doing is pouring the foundation of those silos that we so lovingly talk about. It's that foundation that we've constructed this specialized knowledge construct that, as valuable as it is the source of our inability to get to those dimensions. So now I took you back to Flexner. Let's bring Flexner 100 years. What would he find today? How many of you have been on a committee, a task force, to write the new Flexner report? I know I've been on 3. I see half a dozen hands out there. But we don't understand exactly what Flexner saw and what he would see today. I think, from my perspective, this is what he would see. He would see knowledge moving faster across state lines, across international lines, at a speed that was completely unimaginable in his time, and which dwarfs most of the regulatory structure's ability to comprehend it or to bring meaningful regulation to it. He understood the value of specialized knowledge. He would ask us, why are we standing Luddite-like in the way of that specialized knowledge radically changing? I think he'd also understand the autonomy individual piece. The second thing that he would be struck by is the volume of knowledge. Remember, Flexner was trying to create new bodies of knowledge because the science was just emerging out of Germany, just infecting the American University at Hopkins and at Michigan, and he wanted to add to that. Now we've got more, we're drowning in knowledge. We have lots and lots of data, not a whole lot of wisdom and ability to use it. Second thing he would observe. Third thing he would observe and be absolutely, abjectly shamed by is the shocking cost of the system. And he would have because he was a systems thinker, he'd have the ability to understand that most of what we actually focus on is insignificant compared to the overwhelming social burden of being 1/3 more expensive than any other healthcare system in the world. $680 billion, the exact cost of the Troubled Asset Relief Plan, is extracted by the system that he poured the foundation for every year. They've paid their share back. We continue to take it out every year. The fourth thing that he would observe is this broad set consumer unrest and dis-ease. They no longer trust us. They bring family members to the hospital because they understand that going there is the fourth leading cause of death. Mm-hmm. They don't value sitting in a paper gown on a cold exam table waiting for 30 minutes for someone to come in, reading their file, bringing wisdom to the interaction. They vote with their feet to alternative and complementary care, or they go to Costa Rica to get bilateral hips because they can afford it. So they don't trust us anymore. And Flexner would make note of that in probably pretty trenchant terms. The fifth thing that he would observe is how, and I love the panel of the new academics. Welcome. Good luck. Because what that was for me was a testament that we're completely unskilled to respond to this capacity, to this challenge, and to these problems. I asked an internist once how many things at UCSF we teach residents we teach them to diagnose and treat 850 things. So what if we just took the last 150 things that you'll never see, and we just spent that time teaching you how to make the organization sing and perform and meet the needs of your patients so that you could actually have more time to do what's really valuable, whether you're a nurse or a physician or a pharmacist? What if we taught that as the basic skill? The final thing that I think that Flexner would observe is the incomprehensible babble that we all bring to this enterprise. I have the pleasure or the tortured opportunity to work across from pharma to research to hospitals to health plans to primary care to specialty care. I never find an evil agent. I never find a bad person. What I find are people who have different vocabulary, misaligned intentions, don't have an opportunity to work together. Reinhold Niebuhr in the 1950s wrote a great book. It's one of those books you don't have to read, you just have to hear the title, my favorite kind. The title of the book is Moral Man and Immoral Society. In some ways, it's the watchword for American healthcare system. Moral professional, immoral system. And until we actually get that autonomy of the individual professional out of that system, we'll never get around to fixing those things that we need to fix.
Mm-hmm. Thank you. Mm-hmm. Stephen, you have the last word for this round.
Thank you. Tough act to follow. But actually, I'd like to follow up on your comments on Flexner because
your mic.
Mike.
On the box. Especially knowledge does have some value.
There we go. So what I would like to do is really talk about information management and a challenge that really transcends all of our professions. As you mentioned, we've come from the point where Flexner, who was focused on practicing or developing biologically based medicine, as time has progressed, there's now a disconnect. We've got enormous amounts of information and an inadequate way to provide health care to patients. And just to put that into perspective, in the amount of time that our panel is talking, there'll be about 45 publications that hit PubMed. So if you're every time someone tweets, a new publication comes out in PubMed. So the sheer volume, right now if you look at papers in PubMed, over 1.5 million is enormous. And we're asking all of the professions, asking our students to be able to basically teach and respond to a moving target in terms of the biology of what's the progress of biology and translational medicine. Now, interestingly, one group of professionals that we've not discussed at all are the people who develop the science and develop the medications, develop really the translational tools that ultimately we use. And they're actually disconnected in large part from health profession training. Mark had asked when we talked just before we went on to be pragmatic as we could. Well, one of the things I think we need to think about is how do we bring the basic sciences into the catch-all of translational medicine, realizing the challenges not only of developing effective treatments, but also cost-effective treatments. Now, because of I'm going to tell you things that you probably know. The average professional in this room statistically reads about 400 papers a year. Interestingly, if you look at the amount of time that people spend reviewing papers, the number of papers has gone up. The amount of time that people spend actually looking at papers has gone down. So a lot of the analysis of the literature now is really based on scanning and browsing rather than critical reading. A lot of our students get their information from electronic sources, and the ability or the lack of ability to filter that information, I think, represents a huge challenge. Now, we're talking largely about our ability as healthcare professionals in the global sense to provide care. We're talking about our access to information. In reality, for those of you who see patients, many of you know that patients walk in now with printouts, right? They just as an exercise, I went to, before coming here, I went to Google and said, say I have sinusitis, I want to get some information on sinusitis. So I Googled maxillary sinusitis, 517,000 citations. That's the information that's out in the public domain. PubMed, it's a little bit better, it's about 5,000. But the fact is that in translating and teaching our students how to deal with information critically, how to keep up to date, is probably as important as actually teaching subject matter. Now, we talk a lot about compartmentalization and siloing. When we use electronic media now, how do we gain access to information? We type in a keyword. Rather than look at something in a global sense, a disease in a global sense, cost effectiveness in a global sense, we key in a very, very specific point to get the information. So really what we're doing is going from a very, very broad start to something very, very narrow, and we want to do it quickly. One of both the challenges and the assets of IT is the rapidity with which we can get from point A to point B. But a lot of the times we miss what goes on in between. So I think incumbent on all of the challenges that you mentioned, breaking down walls, expanding roles, is an understanding and a wherewithal to be able to transmit knowledge in some type of filtered hierarchical sense rather than piecemeal and sporadically. Final group that I want to bring into this conversation that we've not mentioned at all is the role of industry. Because in reality, ultimately, no matter how phenomenal a basic discovery we have, for a drug or a therapy to get a device to get to patients, industry needs to be a partner to that. And I think one of the things that has happened historically, and certainly this group is well aware of it, are the barriers that have become erected between academics, medical centers, and industry. And to some extent, there needs to be a balance. But to most expeditiously get basic information to patients, to not include industry in this whole discussion, I think is naive of us. Finally, I just want to mention a third group that also has access to information and needs to be included, and those are the third-party payers, the people who set policy, many in this room, but also the for-profit providers of care. When we think about breaking down barriers, I think we need to be totally inclusive on the informational side, but also in the practical side, speaking to pragmatism, in terms of being broad and open and as sharing and transparent as we can.
Good, thank you. So my job now is to be a little bit provocative in stimulating some conversation among these experts and then to throw it over to you. So I guess I would like to ask 3 questions of all the panelists based on what you've said. First, all of this silo breaking down, all this kumbaya where we're all going to kind of do stuff together, that sounds great from here, but in Albany and Sacramento and Springfield and Olympia and Annapolis, it's a whole different story. And I've heard state legislators in California tell me that the most vicious battles they face are when the ophthalmologists and the optometrists and the opticians come to town. Yeah. Or when the RNs and the LVNs and the LPNs come to town. And so, do you have suggestions about, is there a role for the IOM in proposing some federal standards? Is there some way, Martha talked about state-based solutions, but I guess I want to push back. You said all healthcare is local, but science isn't local. We don't approve this device just for use in Kentucky. We don't approve this drug just for use in Oregon. At a time when information crosses national boundaries at the speed of light, if we've proved that nurse practitioners can do scopes safely, why should we let that be in the hands of 50 state capitals? Is there anything you can suggest about how we might accelerate our capacity to break down these silos that are in the control of maybe 15 different boards in each of 50 states? Stephen?
When they say it's not the money, it's the money.
It's the money. That's right.
And I think the reality is it's not a question of competence. Certainly, there, as you point out, I mean, there are cross competencies that basically any of us could do. I think it's really the reason the state legislatures get pounded is because of the lobbying groups. It's a financial issue. And
the state legislator told me the reason they don't want to give it up is that each one of those groups contributes to their campaign. So my question is, what's the way forward from here?
Well, one, I think, is to argue for regionalism. Here we are in Washington, D.C. If you're going to practice here, you're probably seeing patients from Virginia, West Virginia, and Maryland. And if you're going to move and be fluid or follow the patients, the notion that you have to have licenses in all of these places is an obstructive barrier. Same thing's true in New York City, certainly. Boston, you've got New Hampshire, Vermont, probably Maine, Connecticut, Rhode Island. So I might think this is kind of thing where we could propose. And I think I'm all for pilot studies. It's a great way to get your foot in the door, collect the data, and begin to, I would like to recommend the book called Sacred Cows Make the Best Burgers, and say, let's take those sacred cows and those silos and disrupt it. And see if we can get the data and make a persuasive argument.
Lucinda?
So you cited disruptive innovation, and Clayton Christensen would say that you have to go into a disruption ahead of the regulation. And so recently, we took a group of staff from OMB out to a federally qualified health center where there was legitimate team-based care and measurement of the quality of the work that was being produced. And because they'd never seen integrated, effective care before. And they learned that the clinicians were the happiest clinicians that they had ever met in their life. They met some of their patients and found out that it was really working. And my sense is, and I guess that one of the roles of the IOM is to bring forward the best evidence of what really works. But then we get into the issue of whether policy is really evidence-based or not.
We heard about that this morning.
And I think by and large it's not, because there's a lot of, a lot of special interests and a lot of embedded. So, but I think we have to practice safely out ahead of the regulation and then come back and say, these patient outcomes are better than these others. So let's liberate that practice. Now, I'm Pollyanna, I understand that. I work in Washington. But I really think that with the measurement that we're going to be able to do because of informatics and good measures of quality, that we're going to end up with the unassailable proposition that will ultimately change regulation.
Okay. Ed, you spend a lot of time in this?
Yeah, we do a lot of regulatory. I like Martha's idea. Let's give the license to do it by demonstrated skill. You've got the medical degree, nursing degree, pharmacy degree, dental degree. Now I'm going to sit for the treating diabetic patients and credential that. But here's a more radical, perhaps disruptive. Let's stop licensing professionals and license the system. Gail Warden at Henry Ford Hospital used to say, I violate the Practice Act of Michigan every day I operate because I can't deliver care by not letting this professional be cross-trained to do that. So that's been the third rail in healthcare, but why don't we, if we're serious about systems, let's protect the entry for the profession, for professional identity, but let's license the system that we want to actually ensure the quality and to guarantee the well-being of the patient.
Great. So let me follow my second question, which actually is a great segue, because we've talked about this torrent of information, and the basic paradigm for professional education, continuing education, currency has been that that's your individual responsibility. It's your responsibility to keep up. It's your responsibility to keep up. As you've pointed out, there's more than you can possibly keep up with. It has to be filtered. It's not reasonable to think any individual will be able to build or maintain those filters. Is there a role for placing some of this responsibility for education or providing the tools for currency on the organization rather than the individual? You talked about there being already perhaps burdensome licensure and accreditation requirements, but should that be another one, that a hospital system or a medical practice has to provide a certain set of tools for its practitioners to use the evidence and delivery of care? And what does that do to the traditional system, which is frankly a moneymaker for lots of academic institutions, of individually based continuing education? Mark?
This is a fascinating area because it's my understanding there is very little data that supports continuing education, knowledge acquisition, presumably there's knowledge acquisition, with change in practice, bringing people up to practicing in evidence-based standards and using the clinical judgment. There's very little evidence of that. In fact, the IOM is about to start a special project looking at that at the request of the credentialing associations in nursing. And when I heard about it, I thought, well, this is great, but it should be much broader than nursing, because this is a generic issue and question. I think it's ripe for study. And I think, again, we have to look at what's the relationship between education and competency in practice.
2 points. I think the Joint Commission already says that the system is supposed to maintain the process of competence assessment and credentialing, but I think that the tools aren't as good as they could be. And you're absolutely right. Gail chaired this special study committee on continuing education across the professions, which actually looked mostly at the issue of is there bias in the system as we currently use it. I was on that committee, and we came back to the point that it really is the system employing, because most of us will be employed in the future, that needs to have the tools and the mechanisms, not only as a learning culture, but also a culture of assessing just in time whether or not the individual is keeping up and is equipped to implement the new knowledge at the point of care. And so we really emphasize point of care education, rip up the old continuing education system, and make it a lot more relevant and impactful for the clinicians.
Mm-hmm. Ed, any comments on that?
Yeah, I think that the places that work are the places that have a coherent model of care. So it's intentional, it's purposeful, it's directive. And then there's a professional community, then the best ones are interprofessional, interdisciplinary communities, that seriously take advancing that model of care. I'm going to be fully enfranchised to give you feedback, formally and informally, in your role as a professional. It's going to be a standard for that institution. But you have to have both of those. You have to have the model of care that's intentional, not accidental, which is what we have in most places. Mm-hmm. And you need to have a professional community, again, interprofessional, that's willing and able, skilled to be able to do that, to give that feedback. I think in the few places like Mayo and others where we have that, I think it works, and that's one of the reasons it works.
Okay. Last point. Steve raised the question of the relationship between professionals and industry, sometimes academia and industry. So perhaps driven by some horror stories, seems like every 6 months or so there's kind of an expose about a consulting relationship that orthopedic surgeons have, or a psychiatrist being paid what seemed like unseemly amounts of money to promote new drugs. And in some ways, you've all probably seen now the residents can't get pizza at lunch anymore from the Merck people, because damn those Merck people giving people pizza for lunch. It will somehow sully their independence. And so I guess I wonder if you have any thoughts about the fact that increasingly, as you say, the actual development of techniques, devices, drugs, and others does require a commercialization arm. It requires the role of industry, and yet we're increasingly sensitive, for some very good reasons, about the kind of perverse financial incentives that happen with the wrong kind of relationships. Given the variety of professions that you represent and your different perspectives, do you have any thoughts about where we take that in the future?
I think we should be focusing on confluence of interests rather than conflicts, but we need to manage the potential for those conflicts, and I don't think we've done that very well at all.
It's my understanding that in some, and maybe you know this better, in some like surgical device areas, the clinician brings the corporate representative right into the surgical suite, because that corporate individual knows the most about the application of that technology. So we're living in a couple of different worlds. I'm obviously from pharmaceuticals, and when I found out that they can't do pizza because that's educationally related, but they can do anything that they want in marketing because that's regulated, I kind of thought, well, this is broken, because it's probably the marketing activities that were really out of bounds in the first place, the paying somebody to do a study to introduce the use of a drug in their patient population. I don't have the best answer, other than the fact that I think we've gone probably too far in preventing the transmission of natural knowledge, in-depth knowledge, from those people who have created it into the people who need to learn it and apply it. But I don't think we've come up with the right model yet to fix it.
Yeah, I mean, I think the academic setting is integral to get, just as you need you need industry to get drugs and devices to patients, you also need academics to do clinical trials. And I think the problems have occurred where there hasn't been absolute transparency, where there's a perception that someone is gaining unfairly at the expense of either the integrity of the trial or the integrity of the patient. And as long as that is open, clear, in informed consent, everybody is aware of it, I agree totally. I mean, it should be a much more collaborative. Everybody wants the same thing. I mean, motives may be different, but the fact is, if a company has a blockbuster for a drug, the likelihood is that our patients are going to benefit by it. So,
first of all, I'm shocked to hear that there's money in healthcare. it's an enormous trough, and we're all in it. So I think transparency is the first piece. Inevitably, though, we need some new systems and we need some new structures. Most universities are still structured on a kind of late 19th, early 20th century basis. Most of our relationships with the corporate sector are convoluted at best. A clear, transparent set of new structures. But when we do that, we also have to pony up all of our buy-in and tie-in to federal funding for research and what that means. And if we just say it's on the corporate side, that's only half the issue. And we have to be candid about the budget for our academic health centers and our budget for research, how we appoint researchers, and all of those things. There's great opportunity for it to unleash all this great skill and capacity we have, but we need some new structures and we need to be transparent.
Thank you. So this is where we now turn to you. We've talked a lot about how the system is changing, its growing complexity, its growing wave of biomedical information, the need for a new generation of professionals of all sorts, some of the practical difficulties in reaching this desired state of interprofessional working to the top of license, given that there are 50 state governments and 10 or 15 boards within each of those state governments that has jurisdiction. So now's the time when you get to ask a question, please. A question or make a brief comment. Sir.
Art Kellerman, Rand Corporation. I am optimistically frustrated. I think we do best when we move a little bit but accomplish a very different result. So this is my question. We've talked about a lot of different health professions and provider groups today. There's a group that hasn't been mentioned all day. There are about 250,000 of them. They get paid an average of $15 an hour. They work away from doctors and away from nurses, providing direct patient care miles away, largely working off of standing orders and protocols. They primarily deliver life and death treatment 24 hours a day, and they do house calls. We call them emergency medical technicians. My question is, why do we not have primary care technicians? Why is it that our society is comfortable with EMTs, but we cannot dramatically expand the reach and capacity of primary care in an era of smartphones and iPads with primary care technicians?
Someone want to take on why, are you asking why we don't have a similar group devoted to primary care, or why we don't extend the...
Yeah, no, why don't, we could do it either way, but okay. I mean, clearly there are some pilot programs for like community paramedics, but literally, why don't we create a career path for high school grads and early retirees or otherwise that could dramatically expand the reach of a primary care practice into inner city, into rural Montana, or into Beverly Hills with people who could do that kind of work. I don't understand why we can take care of critically injured patients in a ditch at 2 in the morning, but we can't take care of somebody in their living room.
Because you can't get a physician in the ditch at 2 a.m.
Well, and you can't do it without the physician the way things are currently constructed. So back to the point about doing the pilots and getting the data, and if some of that exists, we need to bring it to center stage and get the spotlight on it. At the same time, Harvey used the comment this morning about, when asked answer to a question, it was about history. It's about history and culture, and it is about the money. The threats that the American Academy of Family Practice or the family practitioners are feeling in regard to expansion of work by PAs and nurse practitioners in the Affordable Care Act, it's about the money. It's about the prestige and the money, and they're threatened, and this is such an unfortunate position to be in because there's more than enough work for everybody, and we need to practice in models where people aren't going to feel they're losing.
Yeah, the point I would make is that in most cities, a city of 500,000 people, their emergency care outside the hospital is managed by one EMS physician and 200 or 300 EMTs and paramedics. I don't propose that level of a ratio, but a family physician or a general internist or a team of nurse practitioners could work with people of that sort and dramatically expand the reach of most primary care. The complicated ones, you need to come into the office. I'll see 5 of them in the afternoon, but I can take care of 500 working with my screen and Skype.
Any other comments on why that hasn't happened?
I would posit that it is happening. I mean, we've talked a lot today about community health workers and these other groups, and I think it's happening. I think that as clinicians aggregate into larger groups than one or two person solo practice, then they can justify adding some of these, these assistant extender personnel into that practice. I think if you look at any of the integrated systems that are out there in existence, particularly those that have capitated models of payment, they're utilizing those players pretty effectively.
And to that point, I just finished a study for an internationally owned emergency response corporation, and essentially the study is how about patient-centered medical care homes on wheels? Because it's just the reverse of your argument. But if your argument is what keeps that from doing it, you just don't have any system that's going to drive that. You don't have enough interest, in the current political context of healthcare. But it could be done.
I would say there may be a database available for a lot of the things we're talking about, and that is the military model.
Amen.
Because they actually do a terrific job with cross-training, practice expanders,
pushing it out.
And all of the competency data are there. And why, I don't know if it's been studied or not, but it's certainly potentially a data gold mine just waiting to be harvested.
Absolutely
Yes,
right.
I would return us to Harvey's comments about the work of Daniel Kamen and Amos Tversky earlier, that this may not be a question of being based on data. Med-techs on submarines manage 500 sailors for 6 months at a time by telemedicine and some training. I'm not sure that's going to solve it. That microphone and then this microphone. Sir.
Bob Rook, Rand, UCLA. I'm going to suggest that you're missing the obvious. And the obvious is that we need an advocacy group, a revolution, and a communication strategy. And I'll give an example. I don't think any one of you identified a single organization in healthcare that has a moral compass anymore. You all talked about it's money first. I think every one of you said it. I'll translate it and say, which health organization has a moral compass? I think that's the IOM. And I wonder whether the IOM can require something of its members and produce actually the communication strategy and the advocacy strategy and the revolution that all of us who are members of this organization need to talk to somebody other than a health professional in a formal way at least once a month forever if we want to maintain our membership, about the things that we have found in all the doggone reports that have been published at this place for the last umpteen years. I'm serious. I don't think this solves, in the United States, any way that we'll like it. If you look at the education system, if you look at Greece, if you look at Spain, it doesn't solve unless we can develop a moral compass and an organization that has one that will communicate effectively and think it's worth the time to communicate to people other than health professionals.
Thank you.
I mean, you know the answers. You just told us all the answers. But we're just talking to each other.
Anyone want to comment?
Amen.
Sir.
Hi, I'm Bill Hazard from the University of Washington in Wake Forest, and I'm a geriatrician. And much of what we're talking about is care of the elderly, either overtly or covertly. But I would hypothesize that there's also a missing voice here, and that's social work. Social work really carries a lot of the mail and a lot of the effort in geriatric care and chronic care and home-based care and getting people through the system. So let's try to make sure they're part of the conversation. But I'm also somebody mainly interested professionally in issues of gender. Gender and communication. I would hypothesize that there's optimism here because I think women do better at this than men. The question is in putting together your teams for team-based care through time, perhaps in the home and wherever, you need to get trust, you need to get buy-in, you need to do it through time, and we need to have a team that can operate with trust and communication and so forth. So how do we teach that? Do we just teach the men to be more like the women? Try that one. But I'd be interested in your comments upon gender, communication, and chronic disease in this regard.
Gender, communication, and chronic
Let's
disease.
start with Steve.
Who wants to start?
I was going to make a comment about social work because in the work of the Interprofessional Education Collaborative, that and psychology are probably the two disciplines that are asked about most frequently. And there's a new CEO of the CSWE. They're the organization that accredits social work programs, but they're also the Association of Schools and Faculty, so they're an interesting hybrid. And as we were talking about, social work's role in interprofessional health care, she acknowledged almost a schizophrenia in that they are healthcare workers, and yet they're social service workers, and it was almost as if she said, I'm not sure exactly which side of this equation we belong on, but we do teamwork all the time. So I actually think there's an awful lot that we can learn from social work. And my opinions on the gender issue in healthcare are interesting because I was in the first class that was 50% female at Auburn University School of Pharmacy. And so I've watched a shift in a profession that went predominantly male to now pretty even. At the same time, I watched a corporatization phenomenon of that same profession, and it's really hard to tease out which factors influence the kind of teamwork, collaboration, and compassion that any one of those clinicians, male or female, bring into the equation, and at least in my discipline.
Other comments?
Well, I often will say about our School of Nursing, there are too many women around here. I mean, our biggest problem on gender is an insufficient number of men. And moving that needle has been exceedingly difficult for all of us. I do think if we had more degrees of freedom on financial aid, and I'm interested in what the Supreme Court's going to tell us about the use of not only race, but gender in admissions and in allocation of financial aid, we could begin to shift that needle more. But it's interesting because these inherent characteristics are rather prevalent. What I've been watching is the extent to which, as more and more women are in medicine and in other health professions, and now far exceeding 50% in many of them, are we going to see a shift as we get into the practice arena? Will they bring those characteristics, or have they been somewhat extinguished?
Yeah, I guess thanks for letting us know there's a little functionality in testosterone.
Yeah.
At least there's a reserve that we can go to. I guess I'm not so much on gender, even though I don't disagree with any of that particularly, but it seems to me that this dialogue between the neocortex and the amygdala, it really is more, let's get the emotional side, this deeper knowledge as a part of what we understand can be a part of teams, how we associate with each other, what does it mean for communication, how do we connect to patients. I think we can understand that with different parts of our brain that I don't think are necessarily gender related, but that seems to be a good avenue to explore.
Yeah.
Stephen?
And nothing to add.
Sir.
Hi, I'm Steve Weinberger. I'm the CEO of the American College of Physicians. We've been very much involved in this whole area of nursing and physicians and the relationship. And I have to say, I think it's really been quite upsetting to see the polarization that has developed. And I think we at ACP certainly differ from some of the other specialty organizations and have very much a commitment that nurses and physicians need to be sitting down at the table together, working out principles and developing that sense of trust and mutual respect, which I think has often disappeared, unfortunately. And we're sending a bad message to the general public. We're sending a bad message to our patients if they see nurses and physicians having this type of conflict. So I think that, we've really got to be sitting down at the table and working together. But I do have a question, and it relates to disparities of care, and specifically geographic disparities. And one of the problems certainly that we face in the physician community is if you go to Boston or to Washington, there are plenty of physicians. If you go to rural Idaho, there are not. And I'm just curious, sort of looking at all of our professions, nursing, pharmacy, et cetera, what can we be doing either in the training environment or in the early practice environment to be getting people out into the communities where we really do have disparities in care?
So let me interpret the question. In an era where we now move information rather than people, and yet people are still important for certain things, how do you want to address this question of the difficulty in attracting particularly more highly compensated healthcare professionals to places that are not so attractive for highly compensated people. That basically is the issue that we're tackling with. What do you think is the mix of technology taking the place of people being there in person, and maybe what are some things that you could do to move people where people need to be?
I want to talk about two. Go ahead, please.
No, please.
I want to talk about two examples where the academic institutions really do have a significant role to play in addressing. Maybe I'll do three very quickly. Minnesota had a radical shortage of rural healthcare practitioners, pharmacists especially. And so the University of Minnesota opened a Duluth campus annex of their School of Pharmacy. They recruited students from the rural area. They taught them in a relatively rural area, and they did their clinical experience in a rural area. And the university fortified the practice in the rural community. They didn't just throw the students back out into the community without faculty mentors. So that was one example, and they have moved the needle on that. University of Southern California has made a radical commitment to the safety net and to the homeless, especially in that city. And they have faculty that they placed in those, they have residents that they have in those clinics. And to their credit, CMS just gave them innovations dollars to expand that to many more of the clinics across the needy areas of Los Angeles. And then in North Dakota, where there are no people except in a very small number of clusters, they've done some really important work in remote telepharmacy and telemedicine. And I guess Mary Wakefield is a piece of that from her North Dakota roots, but I think we will see an awful lot more of that kind of telecommunication that help address the needs of some of the rural populations.
But I mean, specifically to get providers out to areas where they're unmet need. I know, our residents, in terms of their moral commitment to treating patients, have not changed over time. What has changed is the debt service that they come out of residency with. And I think it would be naive of us to ignore that in terms of determining where people elect to go and practice. It's no mystery why people elect to practice in Boston or Washington or LA versus rural Minnesota or northern Maine. I mean, northern Maine is a huge unmet need area. So I think, again, I certainly agree that this topic is not about economics. On the other hand, to throw that out of the equation just is incomplete on our part, I think.
Yeah, for generations, we've been trying to oversupply Santa Monica with cardiologists, hoping one would move to Bakersfield. and that actually, as it turns out, doesn't work and was kind of dumb. So why don't we use predictive analytics to look at those communities that you want to have served? What is it that they need? Let's train for those things. We can, by the time we finish the IOM study, we could have already trained the paraprofessional or the full-blown professional. Let's put them in that community to do class 1 restorations, prophies, manage diabetes, whatever they need to do. But now we know, we train for that, and then we hook them up to technology so that they can get the specialized information they need. But also the other one we forget is transportation. We're going to need to get those people to the specialty care. But we're never going to, if you happen to live in Riverside, California, and you happen to have an aortic dissection, you're out of luck, and there's probably nothing that the society can do. But if you happen to be in Bel Air, you probably can make it to UCLA Hospital.
What? You want to comment? So I guess I'd have two other things to say. One is, some of this is an economic problem, which actually goes back to the lack of universality of health insurance. So there are parts of rural California where it's hard to get professionals to move, not only because they won't be paid as much, but because they're much more likely to run into a population that doesn't have health insurance. And so even if they got paid less, they could make it if it weren't for the intersection between poverty and being uninsured. And so there's actually some possibility, I think, that with the coming of healthcare reform and a much broader set of health insurance, that there are communities that are economically unsustainable for practitioners now that will become more sustainable. Second point I'd like to make, since Dr. Bondurant is in the audience, is that I went to medical school at the University of North Carolina, and as part of my medical school training, the AHEC program sent me to do some of my basic surgery and medicine and peds rotations in places like Charlotte and Raleigh and Asheville and other places that were not Chapel Hill. Now, they're hardly rural, but they also weren't the mothership. And so my sense is, to some extent, this is a question of familiarity and kind of exposure to the fact that these are places where a fair number of people, were it economically sustainable, might find a perfectly fine quality of life and would like to locate if they got exposed to them, and if there is, as there is in USC's case, dedicated, supported faculty who are not just doing it out of the goodness of their heart, but who have some pedagogic training, have an infrastructure to train people. And so it seems to me we shouldn't give up on places that are not New York and Boston. Some of it obviously can be solved by technology, but if people in Bakersfield were much more likely to have health insurance than they do now, and if people who went to school at UCSF had ever actually spent some time in Bakersfield, it seems to me that could make some inroads into that problem as well. Yes?
I think you were first.
I'm sorry. Go ahead.
Robert Ratner, I'm Chief Medical Officer for the American Diabetes Association. We've heard a lot of comment about the absence of teams. The first documentation of a team approach that I've been able to find in the literature was 12 years after the Flexner report, when Elliot Joslin talked about a team approach to diabetes care. 20 years ago, we formed a certification process that incorporated nursing, nutrition, pharmacy, podiatry, behavioral science, and yes, even physicians for certified diabetes educators. So it exists. The problem is the economy. And what we found was that we could keep people out of the hospital and we could shorten the length of stay in the hospital, and that was totally contrary to what the employers wanted, your 26% reduction in income, at which point the entire team was fired. I think what we need to do is stop bemoaning the absence of working together and incentivize it. Behavioral economics clearly tells us people will do what they're incentivized to do. My question for the panel is, how can we change the incentive systems to promote team approach, to promote complementary care, and maximizing the outcomes for our patients?
Okay, how can we promote incentives that can support teamwork rather than being perverse towards it?
I mean, to some degree, we've done that, I think, on some of the surgical services where there's a enormous use of PAs to manage postoperative wound care, getting patients out of the length of stays are decreased. Perhaps diagnostic-based global reimbursement will be a way to do that.
So I wanted to ask Don this morning, but I didn't. The rush to the microphones were so great. I just didn't even try. They have seeded an enormous number of experiments in this Center for Innovation, but I haven't yet had anybody from CMS tell me how they're going to take that empowerment that they got when they find that something works, and without having to go back to Congress to change the payment rules, they're going to change the payment rules. We know that when the incentives are aligned to reward quality care is delivered and sustained. And but the reality is that there are misalignments in the current payment models on both the public and the private sector side, and those have to get changed.
Well, I think we're seeing a shift from only fee-for-service to the bundled prices for a product and for delivery of a product. So if you have a team that's mixed, as was just described, you can deliver the outcomes, within the team, you can then take the allocation, you get the bundled price, and sort it out within. So the notion of having team members who earn less money as an economic matter is attractive and makes sense. And I think we're going to see more and more mixed models. We're going to see more examples of success. They exist. I mean, you can go back 30 and 40 years and find them. I think it has to be that the current model that focuses on procedures and hospital-based care, fee-for-service, is...
Well, there's a pro fee in the... yes.
Well, and if you have an admission and then you get 17 or 18 bills from different departments and then from different providers. I went to the president of the Johns Hopkins Hospital, I laid it out for him, and I said, if I go to Nordstrom's, and I buy a pair of shoes in this department, and then I go to another department and buy something else, and I go to another department and buy something, I have one bill. what's with this situation? I know why it exists, but it's just seriously annoying and a real imposition on patients, not to mention creating a whole bureaucracy. So there's certainly a simpler way to do it.
There are three big things. First, at the macro level, we've already talked about it. For the first time in all of our professional life, the market and the policies are more or less aligned. Not perfectly aligned, but better aligned than they have been since the Second World War. The second thing that we need is exactly the kind of research that you just described about what outcomes we get for whatever we change. It doesn't have to be a team. Sometimes it might be a paraprofessional working in the Central Valley. Let's get the outcomes data. We don't have perfect outcomes data. Let's keep working on that. It has a 15-year time horizon. The third piece that people don't mention, we talk about the first two. Let's align payments. Let's make sure we have the outcomes to be able to demonstrate what we need to be paid for. The third thing is we need systems that have the courage to push this integration all the way down, as opposed to stopping the first time somebody objects because we're going to standardize, we've been picking on the orthopods all day, standardize the hips that get replaced, or we only have nurses who are going to wash their hands. Until we get institutions, systems that have that kind of integrity, then you won't get the follow-through, because then they'll prove themselves competitive.
So this was actually one of the areas of which I think our committee was optimistic, in that there are examples now, some of them seeded by CMS in the various flavors of ACOs, but some of them in the private sector, to try to create organizations that are willing to take longitudinal responsibility for both the clinical and financial outcomes of a group of patients. So there are some big organizations like that already in California, but there are a number of others that are forming fitfully by fits and starts, sometimes around comprehensive care, sometimes around bundle payments, sometimes around episodes, and like it or not, it will probably take some time before these things get worked out, but there is at least progress toward a situation where the system as a whole no longer has an incentive to not only get rid of the kinds of clinics you described, but coag clinics and all sorts of other clinics, congestive heart failure clinics. There's a series of them that have been demonstrated to be inimical to a reimbursement system that favors inpatient hospitalization. So again, I think this panel would agree we're not there yet, but we're a lot further towards there than we were 5 years ago. It remains to be seen how quickly that process can develop.
So adding to the conversation, Martha touched on people who get paid less, and that's the personal care workers, our nursing attendants, home health aides, whatever you want to call them. They're 4 million plus strong, and they're usually women of color right now. And those are people who might be making minimum wage and don't have health insurance. And so while we're having all these conversations, I think it's really important for us to just make sure that they're in the front of our collective consciousness. Thanks.
Excellent point. That's a huge need and a growing need.
Oliver Fine from Weill Cornell. I know this is not the direct question that this panel faces, and you've touched on it a little bit, but the issue of payment reform as a crucial way of moving in this direction, and whether or not a for-profit private health insurance system is it all going to truly allow us to move in this direction, or does it give us that problem of not having the moral compass to move in that direction? I'd be interested in the panel's response to the notion that maybe we ought to, again, be thinking at this time about a single-payer national health insurance program as a way of getting to the universal coverage that Mark spoke about and really being able to implement some of the reforms that you've been talking about.
So, comments by the panel?
I think there's a growing sense among average clinicians that the complexity of the current system is unsustainable. Sometimes you do hear an advocate for a single-payer system. I'm quite frankly not sure I see a lot of difference in the behavior of some for-profit corporations versus some not-for-profit systems, because at the end of the day, there's a bottom line. Some group benefits more perhaps individually in the for-profit scenario, but I'm not sure it always changes behavior dramatically. So I'm not answering your question yes or no, but I would say that I hear providers so frustrated by the system of 17 bill complexity that they're also having to administer, that the status quo is no longer much of an option.
I'd just like to comment that
we've had this discussion before. I mean, my only anxiety about single payer is that it's a form of wage price freeze. And I think if we freeze it at 18% of GDP, we'll never reduce it because there won't be any incentive, and because we won't give anything up, and we can't sustain 18% of the GDP. So just at that most macro level, I have anxiety about that.
Well, I think when people say we have the best healthcare system, I totally disagree. First of all, I don't think we've got a system. Secondly, I think a lot of what we have isn't about health. And having lived in France, they have excellent outcomes and a very, very efficient systems. Cuba has much better outcomes than we do on maternal child, despite all the work that Ruth and others have done. So I think we really need to get that moral compass set on what really matters and what are we trying to do for us as a society. And again, what do patients and family need? We're all patients and families at one time or another. And it's taking the shift off of what it is that the providers need or these systems and organizations we've created need. To what are we doing and what difference does it make? And I think there's some tough, hard conversations to be had.
Yeah, I think there's a gap between need and want.
Well, sure.
And until that Venn diagram comes together, it's going to be a very protracted discussion, I think.
We've created extraordinary expectations on the part of people. Everyone is quite entitled.
Yep, absolutely.
And
So we're out of time. Let me end with this. It is always tempting to revert to a conversation about these big questions about how the system ought to be organized. One of the things I would point out is that there are good things happening. In the report that our committee wrote, we could show you examples of all the ways in which we'd like to see the system working that are working now today, despite the fact that there are for-profit insurance companies, that we don't have payments aligned, that we have all these problems. And so I just urge us in our various forums to push towards big solutions, but to not have that push take the place of doing whatever we need to do and can do in our own institutions today, because that, it seems to me, is the way we make progress. Please join me in thanking our great panel.
I think we went to the wrong school.
I grew up in Connecticut.
Let me also thank Mark and this panel. It was really quite a spectacular discussion. I am reminded of one thing that I alluded to this morning, which was in relationship to Don Berwick. And I alluded to the fact that at the time of the Olympics, we all saw that one of the things that was celebrated in the UK was their National Health Service. I think it's hard to imagine that if we had the Olympics in the U.S. that we would celebrate the U.S. healthcare system today. That reminds me of a comment that I'll allude to made by Winston Churchill, which was about America, and I'll paraphrase it roughly to say that he said that the thing about America or Americans is they always get it right after they've exhausted every other possibility. So I think we're certainly in a bit of a transition, and I think the last comments from Mark speak to that. We're moving towards something and away from something at the same time. What we haven't addressed so clearly is that part of our confounding has been that we've been part of a market-based healthcare economy, and at least the promise of a healthcare system through the Affordable Care Act, even with all of its imperfections, begins to move us in a direction. And that direction is going to be certainly enhanced as we think about transforming professional education for the 21st century.